This is Just Say HIE, the official podcast of the Hope for HIE Foundation. I'm Betsy Pilon, your host, bringing the stories of the HIE community from around the world to you, our listeners. Hope for HIE is a nonprofit organization and the largest collective of HIE families anywhere in the world, and each story across all outcomes has its own version of hope to share. Join us as we explore each unique journey and connection. Happy HIE Awareness Month. I am Betsy Pilon, and I'm so excited to welcome Dr. Monica Arroyo to our kickoff of our Q&As with our Medical Advisory Board educational series for HIE Awareness Month. And we're so excited to have you here. Obviously, you and I kicked off April 1st for Awareness Month recently. We actually got to meet in person, which was so fun, in Cincinnati at the National Association of Neonatal Therapists Conference. And I know our community is so eager to hear from you and your perspective and get some of the questions that were submitted answered, to the best that we can. So why don't we start and tell us a little bit about yourself, kind of your path through, choosing to specialize in pediatric neurology, and then in particular with, neonatal neurology.
Thank you, Betsy, and hi, everyone. I'm so excited and looking forward to spending a little bit more informal time with some of you who I wouldn't get to meet otherwise. My name is Dr. Arroyo, or Monica. I'm a pediatric neurologist, and I practice in South Florida. And out of all of the specialties in medicine, I think neurology is the most interesting. And out of all the people, all ages, the babies are the most fascinating. And they have this amazing ability to recover from different degrees of brain injury in remarkable ways. So babies keep us on our toes. And I really like the idea of being there for families in the worst day of their lives, really, and kind of helping them through that. So that's kind of how I got to be sitting here today. That's
wonderful. And I know we've had so many people ahead of this event share, that are patients of yours, share how, what a wonderful team cheerleader you are for them and working with them as well. So I'm just so excited that you could join us today. So we can get this started, and we'll start out. I know we had some questions. So I guess, from your perspective, as we, where did this go? Here we go. Starting in the NICU in particular, what is kind of the follow-up that you think, as babies go through the NICU and get discharged, what is the ideal follow-up for HIE babies?
I think it depends on a few things. I think the most important thing has to do with location where you are. In some places, you are lucky enough to maybe have the same neurologist you saw in the NICU. If you get along with them, follow you because they already know the whole story. So it's easier to get down to business in the outpatient setting. Even though it's helpful to sometimes relive the past, as painful as it is, but just having someone that was there is helpful. And I think it depends on the medical needs of the child. We're learning from newer data from the neonatal seizure registry that some babies don't have to leave the NICU with medicines, but still some do. So if you are leaving the NICU on a medicine, that might mean that you might have to see neurologists a little bit earlier, just to make sure that if they need to, whether it needs to be increased or decreased, that you have that time. And I think, the milder cases where we're following development, I think it would be okay to wait a few months, maybe 3 to 4 months. I can tell you in our follow-up clinic, if it's a mild case, I like to see them back at around age 4 months because it helps me see what they're doing at that time. Sometimes we do an appointment in the middle. Now with telemedicine, I think it's helped have a little bit more availability. And especially if I feel like the family would benefit from having an appointment in the middle. Maybe at the 2 month to just make sure A, that they're enrolled in therapies, B, that there's no new issues, And sometimes by then, maybe mom has had her OB follow up and maybe has new questions. So we have a dedicated time. But it really depends on resources. There's not a lot of pediatric neurologists in the United States. So I can see how things could be stretched in different places. But in general, milder cases, I think 4 months would be okay. And in more severe cases, probably earlier, would be ideal.
That makes a whole lot of sense. We always get a lot of questions about cerebral palsy, because that's one potential outcome for our kiddos with a wide range of impact, from very mildly impacted to very severely. So how do you diagnose CP? What do you feel about the role of MRI, and what criteria do you use?
Yeah, so it's a tough one because CP also has so many different types. So some of the more severe presentations of CP, you might be able to diagnose pretty early, like under a year of age. There are some tools besides a neurologic exam that can help you. There's something called the Hammersmith Infant Neurologic Evaluation Scales, which in my clinic, I have the physical therapist do herself, and then I do my exam and compare notes. It's really helpful actually to do that. There's also something called the GMA, or the Generalized Movement Assessment, which is another standardized test that has good predictive value. Even in the earlier cases, when we're not sure what we're seeing red flags, I feel like it's important to discuss, we're seeing some changes that, we're concerned for CP, and having an open communication can be helpful, because if you discuss what you're seeing, then the therapy team can and mom and dad, of course, can target those things we're seeing, whether it's one side being weaker or tighter. And then if we end up making a diagnosis a little later, when it's more set in stone, this side is different, then it's not a big shocking surprise. We've been noticing this. And also mom and dad can start noticing too, and give you input on is this something that's happening? This baby is fussy in the office, and I'm seeing increased tone, or hey, even when I'm bathing baby or changing baby, I'm seeing this too. So all comes together. The milder cases, it might take us a year or two to figure out, and definitely when it's just movement disorder, it varies. It's very varied, but I think having a conversation and looking for it earlier on makes sense in an open way. In terms of the MRI, if we have an MRI from birth that shows risk for CP, and I'm seeing a child, say at 9 months, and I'm already seeing, say the legs are tight, like a spastic diplegia, I'm putting the baby on the exam table, and the baby is scissoring their legs, so not putting the heel on the back of, like not planting the foot. Putting those two into together, I don't necessarily need to do another MRI at that point to make a diagnosis. I'll say, we have an abnormal MRI, we have an abnormal exam, and sometimes another MRI is helpful to sometimes a later MRI can show more things as the brain is changing. And even if you wait till age 2, you get the best or, a better MRI, but it's not necessarily needed to make the diagnosis, in my opinion, if you already know you have an abnormal brain. If it's a baby from the community that wasn't in NICU, even if the birth history is a little different or concerning, I still get it, because we just don't know, right? And then we could be dealing with something else. There's other things that look like cerebral palsy that might be a genetic issue or a white matter problem in the brain that's progressive, which is different. But I think it's HIE babies, if we already know the MRI is abnormal, or if the MRI was normal for an HIE baby, which can happen, right? And then you have an abnormal exam, that might be another reason to do an MRI a little bit earlier to clarify things, make sure nothing else is going on. But it's really more of a clinical diagnosis, and imaging, if you already have it from birth, you put 2 and 2 together.
Right. Yeah, and this question comes up often, because I think there are a lot of neurologists that do want to look at getting a follow-up MRI at around 2 years. I remember ours in particular, when Max was 2, he said, how do you feel about a repeat MRI? And I said, well, what would we learn from it? And he's like, well, you already know that he has cerebral palsy. So he's like, it's for my own personal interest, not necessarily for, it's not going to change the course, but certainly there's the asterisks to that of like, if there's other concerns or other things that, to qualify what you were just talking about too. And just the conversations that come up with, parents wondering about that.
And, neurologists love MRI. So we would get it all the time if we could, but it's a procedure that requires sedation most of the time. And it's a stressful procedure because, again, I always tell this to my families, is a picture of how the brain looks, not how the brain works. So sometimes the MRI can look significantly worse than a child. And then how is that going to help us at all today, right? So there's a lot to juggle. So it's a decision that I like the idea, like how your neurologist did it, kind of a shared decision-making model, so that we all know if we decide to do it, well, we're kind of embarking on it and understanding that it's not going to change what we're doing. We're still going to do therapy, right? Still going to be CP.
Well, I think that quote I want to cement in stone of an MRI is how the brain looks, not how the brain works. Because that, I think, is such an easy way for people to understand, because MRI can feel so complex when you're getting results back and talking through them and looking at, potential impacts, especially, like when we get MRIs in the NICU and things are very, very difficult, lots of difficult news.
And it's not even only for parents, or that this is a weird concept. Like I have colleagues in, for example, cardiology, right? They do a EKG and an echo, and they're like, we know the function of the heart. And they'll ask us for an MRI, well, what's the prognosis of the child? Can I operate on them? I'm like, it doesn't work like that for us.
Right.
So I think it's not even just parents. Sometimes the perception in the community, even within our own colleagues, even maybe some neonatologists might think. But us to take care of children for the long run, know that it's, sometimes the MRI is surprisingly bad compared to a child. And sometimes the MRI is surprisingly good compared to a child. In pediatric neurology and the non-HIE world, we have kids coming in here with severe issues. And guess what? The MRI is normal. So we're very comfortable with that, but some of the people just don't understand it.
That's really helpful to hear and work through that. Again, that's something that comes up all the time that families that they ask about with MRI. So, one of the actually a few of the questions, and now we've had I know some that have come through the chat, is regarding microcephaly and head growth. We know that microcephaly is the definition is small head, right? So, and it's one where, I think a lot of follow-up clinics, everyone measures the baby's head a million times in follow-up clinics, and it becomes a point of stress for families. So I think if we can give people a little bit of understanding around it and where it needs to belong in our bucket of worries, that would be great.
Yeah. I think it's part of the way I think about it. It's part of what's already happened, right? It's not a new problem. And I tell this to my families, and I show them the growth chart, and I say, I'm not surprised the baby's head is not growing as much as the weight, because the baby had a brain injury. And I think what people don't understand is when the brain has an injury, those cells will never be the same. So they don't really grow as much as other healthy cells. So if you think about it, there's less just tissue kind of growing. And if a baby has had a big area of the brain that's changed, those cells are not going to be growing and pushing out, right? So it's not shocking to me, but say if they were in a pediatrician's office and they were like, the head's not growing, we need to talk about the neurologist. Like, yeah, I know that's not growing. And again, picture how the brain looks or how the brain's growing. But if the child's doing okay, we keep on keeping on. We're not going to send genetic testing for microcephaly, like, oh my God, does the baby have another problem? No, it's all part of it, right? And maybe we can do a better job in our counseling, maybe for the more severe cases, say, listen, as the baby, just like we kind of try to do a good job at development and other things, just say maybe being more mindful of including that information. Like, as you go to the as we see over time, we might find the head doesn't grow as much as the rest of the body. And that's also part of this injury that's happened. And maybe knowing about it from beforehand, just like we talk about seizures and other things, could be helpful. So I think this is something that I'm going to remember to start telling people. And I tried to look in the literature, and there's really no literature on it. So maybe that's just even a project we could do,
Right.
and put it out there so more people just think about talking about it, and then it's just not as stressful.
Yeah. And I mean, anecdotally from information sharing, I mean, I will say that this is probably one of the most common questions that comes up as new families start going to follow-up clinics and getting their kids' heads measured so much. They're like, oh my gosh, I've never heard of this. Anyone else? And it's literally one of the most common questions asked. And then what you inevitably see are families chiming in with beautiful pictures of their kids, and saying, as soon as my kid grew hair and we put or grew up, it's like, it's so much less noticeable. But when you're staring at a newborn baby and you're like, oh my gosh, now I see that,
And if you Google microcephaly, you'll run into like other scary genetic syndromes, and then you start to question, does my child have this now? Or I think maybe just, again, doing a better, maybe looking at it, how much does it happen? I think it happens a lot because it makes sense, right? Brain's not growing.
Yeah.
And then just saying, if this is going on, it's part of, could someone have bad luck and have two things? Maybe, right? And we see that too, but the majority of the time it's just going to be part of that injury that occurred already. Bad news we already had, but stressful to hear. Like, I've had parents tell me every time we go to a doctor there's a new problem, and it's all related to that, but it feels like a new problem.
So the thing we always do is to encourage people to throw out their measuring tapes. Because
there you go.
You can get in the obsessive head measuring club.
Just put the MRI in the same trash can. We're good. Just put it on the trash can.
A point in time. All right. So definitely some questions about seizures and epilepsy. We know that HIE is the leading cause of neonatal seizures. And so, some of the questions are like, what are some suspected symptoms? Like, people don't know a lot of times, unless their child has active epilepsy, what even to look for. Like, and, one of the gap areas is really from discharge of NICU into those later months.
Yeah. So neonatal seizures can look like a lot of different things, and I'm happy to tell you a few, but those are not the more common worries we have with HIE. So with HIE, the biggest seizure type that everyone should know about is infantile spasms, and these are stereotypical movements that involve upper arm and the trunk to various degrees. It can be really subtle, more like this, and the more classic seizure is when you kind of have your whole involvement, but like that. But it happens in little groups, and sometimes we see it more in the transitions between being asleep and awake. And so little groups, meaning that they'll kind of have the seizures back to back. And sometimes babies will cry after the episodes, alerting parents that they're not feeling well or something's happening. And these are things that happen like a lot throughout the day. So if you're seeing something that looks the same, and your parent gut feeling is kind of like, what is this? I think the best thing to do, especially HIE baby, take a video, call your neurologist. If you can't find your neurologist, talk to your pediatrician, take them to the ER, whatever is more accessible, because with infantile spasms, the earlier we treat it, the better the outcome. So definitely those our community needs to know. In terms of neonatal seizures in general, there's lots of different types. Sometimes you might have motor movements. A baby's nervous system is immature, so they cannot do things like this, like reach for a toy. They can't, right? So as they're practicing, they kind of go like that, right? And if you're a mom or a dad of a baby and you were told they could have seizures, you're going to see that and you're going to be worried, right? But if it's non-rhythmic, kind of high amplitude, you can always try to stop it, okay? Things from the brain, you try to stop it, they might kind of still go. You can try to stop it. If it stops right away and the baby looks calm, nothing. But if it keeps going, the thing to do, look at the face. And if the face looks like something's going on, not blinking, you can take the time, kind of see how long it's lasting. And if you're worried, just call someone for help. Just call your neurologist. But if it's actively happening and not stopping, you can call 911. That's where we all pay our taxes. No one's going to fault you for calling 911 your baby that had HIE and you don't know if you're having a seizure. Just, you can always do that. But nervous system immature, babies with lots of trembling. There's another thing that can look like a seizure to some parents is something called clonus. When you tap on the baby's ankle, if they've had a brain injury, no matter how severe, babies will kind of do things like this. They typically stop after a few times, but if the nervous system is abnormal, it can kind of keep going. And you might elicit it with touching even sometimes like tapping the bed or something. You might see it and be like, oh no, what is this? But that, again, you can stop it. It's weird for some parents ask about staring spells on babies. That's kind of an odd seizure type. Baby's vision is still developing, so rolling your eyes back as they're drifting to sleep while they're feeding, that's normal. If you ever see the eyes fixed to one side, that will be weird. You can pick the baby up and kind of spin them around, and if the eyes are just fixed to one side, not blinking, these are the type of dramatic things that would make us think of seizure. But again, if you're not sure, the best thing to do is, to take now with everybody's smartphones, take a video. And if something's happening over and over, it's best to just talk about it with your doctor, and just to make sure. But infantile spasms is probably the bigger one to watch out for.
Yeah, for sure. And there was a question about, onset with IS. Typically, I believe it's between 4 and 8 months, right? And then
it can be a little bit earlier. It can be a little bit later. Sometimes kids don't read the book. If you see something like looks like it, just better safe than sorry. Some of the mimickers of IS could be things like reflux, like with the back arching and other things related to feeding. But again, no one's going to fault you. No one's going to think you're crazy. No one's going to think you're ridiculous. If you are concerned your child's having seizures, that's a big concern of us too, for us too. So just better to get help.
Yeah. And a follow-up question to that is, at what age are kids typically out of the woods for IS? I know this is hard.
Yeah. They're infantile, so you kind of really nitpick at the word. You'll say, after 1 year, but probably yes. You can develop later other seizure types that could look like IS, but I think I would say by a year. I don't know what you think, Betsy, since you've learned so much about IS in the last 10 years.
That's the most common, is saying that they pretty much, the onset would be not past a year, but there are, of course, HIE is complex, and so is epilepsy. So there are, it would be not be called infantile spasms at that point. And typically I've seen it called epileptic spasms, which would be
epileptic spasms,
a similar type, right? Just out of that period. But why it's so important, again, to see about getting early treatment for IS. So if you do have it. So, and then, obviously this question begets another question, which is, just seizures and epilepsy in general, and where we see different times that are common with epilepsy onset of kids that might not, have had control from neonatal seizures. We know they're, kids with HIE are more at risk of developing epilepsy than the general population by a little bit. So I've seen some literature, but I'd love to hear your, perspective on that as well.
We don't know a lot, right? We're still learning so many things about HIE. I feel like the school age time is more vulnerable. I've seen it with kids with neonatal stroke as well. 6 years old, 7-year-olds, 8-year-old. I think, I don't know, this is like my hypothesis, is the brain is changing in so many special ways during that time. There's so much growth. Maybe those little short circuits that gave us problems before kind of maybe spark up again in a way, and we might see them, but it's tough. I wish we had technology to predict, because of course you don't want to live your life thinking that, hey, when is the other shoe going to drop, right? Like, my child already had this birth injury, already had seizures, because it might not happen. But it's so hard, even for us, ethically. We do warn, hey, sometimes seizures come later in life and we don't know when. School age is of concern, but we might not see it either. So it's really hard. And even with the best literature out there or looking at literature, every child is their own universe. So all we can do is at least mention it. So if it does come, it doesn't feel like, what is this? Another problem, right? It's all kind of part of that first problem that we already know about.
Yeah. And, we recommend that families go through seizure first aid training regardless, because and understand, just being aware, again, like you would be CPR trained. It's a skill set you hope you never have to use, but in case you would, and I think one of the messages that comes clear from a lot of neurologists too is that epilepsy is just common, in the general population as well.
It is.
So obviously with HIE, we know that there's a higher, percentage, but that it is common, and that knowledge of what to do in case a seizure happens could not only just help if your child develops epilepsy, but your neighbor or someone else, that you would come upon and is experiencing a seizure. So there is a free seizure aid first training through the Epilepsy Foundation that we link to. And really, it mirrors the education that you just spoke about IS too. If a child is seizing, trying to get them in that safe position until the seizure is over, calling 911, especially if it's the first one. And then if you can get a video of any of it, even though you're in that emergency situation, that video can be super important for the neurologist to help identify what type of seizure it was too.
Yeah, I think videos are so helpful. I mean, sometimes we're like, somebody sounds like a seizure and you look at the video and you're like, I don't know. And it helps us know how concerned to be at the moment. But I totally agree that, yeah, seizures are just so common, even febrile seizures, right? Even more common. So I think, and even for us neurologists who are specially trained to help with seizures, I think it's like human nature to get this feeling of immediate panic when you see someone having a seizure. So if it's your own child and you're in your home, it's the worst of times. It really is. And I think knowing a little bit beforehand what to do could be life-saving and also kind of help you get through it a little bit better.
Yeah, definitely feeling a little bit more empowered in a situation that we always want that sense of, maybe not everyone, but want that sense of control. But if you can have a little bit of peace of mind, basically, behind things, it can help maintain or decrease that anxiety as well. So another question, that comes up, what do you think about stem cell therapies, HBOT, other alternative therapies that are out there that I'm sure get mentioned in your clinic and get mentioned in a lot of different clinics?
I know this is such a tough question, and I know it's always coming in any encounter with families that have been doing the research and in situations like this, because I think the reason people ask is because there's not a lot of things available, right? So it's kind of a call to action in many ways. I know that you're going to have another session later this month to talk about the therapy needs with Dr. Barber. So I hope maybe she'll touch on that too. I can tell you my personal opinion. I mean, I think stem cells are very promising, but we still as a medical community don't really know, what's the best stem cell type? When is the best time to give them? How to give them? Is it through the nose? Is it intrathecally? How often? What dose? Right? So when you think something's helpful, but you still have so many big questions, it's hard to make a recommendation, right? I think it would be great if there were trials that you could go on. I think that would be the safest thing to do. But I think there's a lot of promise in it. I just formally cannot make a recommendation because we just don't, it's just too many questions for me as your doctor to be able to say, well, let's go check this out. Okay. Hyperbaric oxygen therapy, it is a medical specialty, right? There's actually doctors that train to use the hyperbaric chamber because it has a lot of medical applications, mostly when it comes to infections, wound infections, right? Because it kind of helps your blood have a lot of oxygen. And there's even some literature on traumatic brain injury and using it to help with awareness and in cognition, right? There's still not a lot of data on HIV, so it's hard to know. It's again, same thing. Is it safe? How often? When? I've looked into it for near drowning because I practice in Florida, and unfortunately, it's the worst thing. But we get people, children that walked out of the house and are found down in a lake or one of these like man-made lakes or swimming pools, and we just don't know. And we've looked into it, and there's case reports, but even with a case report, there's not enough to say this is life-changing or this can help. I do, get a little nervous about it. Maybe it could cause harm. I think these questions are a call to action for more research. In terms of other things like, alternative therapy, like chiropractor, as long as there's no neck manipulation, if it's massage or anything like that, I think that's fine. Acupuncture for a baby, I don't feel too comfortable with that either. I think for mom and dad to deal with stress, absolutely. I've definitely done it myself, and it's great. So I think with everything in life, you have to think of the pros and cons. I do worry a little bit too about the cost. I've had families spend a lot of money on things that we just didn't think from the get-go they would work. So it is really, really tough. But, these questions are important to ask because I think we need more research on these areas.
Absolutely. Thank you for that. So, a lot of questions have been coming in, and I know we had one in the Q&A that that we're addressing too, is, what the, common or frequent issues of like more of a mild HIE might be either in the first few years or, what could come down the road.
Sorry, I just got a little call. I hope I'm
fine.
back. Am I back? Okay.
All right.
Okay.
Yep, you're good.
Okay, I'm back. Okay. Well, so I think this is like mild HIE is kind of a little bit of an unknown territory. I think we are still, again, not to keep being redundant, that we need more research, but there's a lot of things we still know. I think one of the things that with my mild HIE cases that I talk with my families is we need a good pediatrician, right? Because you're going to see a pediatrician more often. And when I say good pediatrician, my preference would be if we can get into a practice that you'll see the same person each time, because it's kind of traumatic to be explaining everything again. And like, right, and this community has been very vocal about this month so far. It's like we're sick of people telling us everything's fine or kind of brushing us off, right? And the last thing you want is a pediatrician at 2 months that's just gonna go, oh, heart sounds good, belly's soft, shots and out of there, right? Because you are a parent that has more concerns, you're a parent that has more questions, and to feel dismissed like, oh, there's a history of HIE, oh, but it's mild, everything's fine. You I think any parent with a birth trauma probably benefits from a good pediatrician that will like check the head control and like just like do a little bit more to make you feel more reassured, because again, in the best case scenario, you'll have neurology involved, but this is very resource dependent, and you might not, but the pediatrician you will. So having a good pediatrician is helpful. I believe having early intervention when you have a diagnosis of mild HIE is necessary, right? Because it keeps you looking for signs and symptoms before they become a problem. But again, this is resource dependent, right? So if that's not an option or that's not available, having a good pediatrician can kind of fill the gaps if they are seeing concerns, even if it's something mild like, oh, the neck's a little tight, you have mild HIE, let me just send you to PT, just kind of like make sure everything's okay, can be reassuring. And in terms of the long-term effects, I don't know. I'm curious to hear in the future if we find there's any like cognitive or attention issues that could come up. I can tell you in my general child neurology practice, I always ask about the birth because I'm interested, right? And sometimes, parents are like, oh, it's fine. The cord was wrapped around the neck. It was fine. I was like,
totally
oh, okay,
fine.
okay. Well, he was blue, but he was fine. I'm like, okay, well, now we're seeing these problems. So, I just kind of wonder how, and it's a coping mechanism, right? You can't go through life like, oh, the child was blue. We didn't do anything about it and thinking about everything. But, like, understanding that there is a risk, or, hey, there was a perinatal depression, or those words that some doctors like to use if they don't get cold, just to make people aware, hey, maybe there's something about the birth that was a little different and later on could creep in. I think for mild cases, when all the milestones are good, including language, cognition is going to be your next frontier, right? Age 6, 7, 8, particularly for me, third grade is the telling grade. If you do well in third grade, you're pretty good. Because third grade, it becomes more abstract. It's very language based. A lot of kids with learning disabilities might coast through first grade and even second grade. And when they get to third grade, things fall apart. So I would say the early school years, I would still worry about that. If things are okay after third grade, I would want to hope that everything's fine after that. But again, school cognition, we don't know until later. So if you're running around the office at 2 and talking and you have a history of mild HIE, we might not be out of the woods yet for a problem.
Thank you for addressing that. That is definitely a very common question. And, I think like anything else, when we talk about early intervention, there are, and there's sometimes gaps between the medical side and the educational side. That's a chance as well to kind of just be, engaged with checking in. And can you talk a little bit about what the brain goes through? Because I know, things that I've read and understand is that at that time, that's when the frontal lobe is really starting to develop a little bit more. We're talking about higher order thinking and executive functioning and, those higher order level, tasks and things.
Yeah. And so all of those things are happening. And that's why even things like attention deficit hyperactivity disorder, we can be very suspicious about it, even at age 3. You're like, oh, wow, you're very hyper. But really, once you get to that school age, I mean, if you look at the DSM, it's preferred after, age 6, right? So these are the times that you can kind of more confidently say, this is not a big, my brain's still maturing. It's more like I have arrived at this age and the things that are expected of me are different. Neuropsychology evaluations too are very helpful. Again, done after age 6, way more valid. I think families of children with mild HIE should be prepared for school entrance and know the laws and resources in their state as it tends to the education system. I mean, there's things that are federal, right?
Yes.
You have a right to request an IEP or an individualized education plan. And the first step of that is psychoeducational evaluation. So that is something that a school psychologist will do. And that has to do with how you're thinking and reasoning and academics. So, letters, numbers compared to other kids your age. It doesn't always include what's called an IQ test. An IQ test is a specialized test that has to do with how your thinking and reasoning is compared to other individuals your age. And you can look at verbal IQ, which is how you think and reason with language, and nonverbal IQ. And the tasks that are nonverbal are like copying complicated blocks or, doing things that don't require language, right? So some kids are nonverbal and might have a normal nonverbal IQ, right? Because their ability to think and reason is pretty close to normal, but their language is impaired. So if the school evaluation is not enough, right? You can always get that neuropsych evaluation. And I think neuropsychologists, at least ours here, really likes when you have the school evaluation so she can see what's been done and kind of use that information as a parting point. And the school evaluation is free of cost. And if you take a letter, and there is the AAP has a sample letter, and it should be in your pediatrician's office. We have it here in neurology office. You just request it in writing. My child is 6 years old and he's in the first grade, and I need you to evaluate him for an IEP. I'm concerned about their learning. And then they stamp. Pediatrician's office will stamp it, and they have 60 days to respond. What that really means is to call you back and schedule, again, resources. But these are things that are available to you, because sometimes the teachers are exceptional human beings. I mean, they're like, I have so much respect for teachers. They're so smart and they're so caring, but they have so many students in the class, and they might not get to know your child like you do. And this history of mild HIV. Maybe they don't even know what HIV is, right? That we're raising awareness. Maybe the teacher doesn't know, sees a child that's pretty good, she doesn't know, right? So you as the fiercest advocate for your child can kind of get the wheels going. Here in Florida, we actually have an advocate program where if parents are having a hard time navigating the school system, there is this dedicated team of people that speak many languages, and then they will kind of help you. And Epilepsy Florida has a school advocate too. So if things are not, because having epilepsy is another risk factor for having some school problems, right? So there's a lot of other entities that will help you navigate the school. It's really hard. I have parents that are teachers themselves, and they're still like, I cannot get this IEP going. Or sometimes the saddest part, you can have the IEP, but for some reason the school is not able to do all of the things. So it's just so many layers, and it's trial and error, right? So some you think kids are going to do great in this setting, then maybe not. So pull back, add this, but again,
it's a living, breathing document, which I think sometimes, people are like, oh, we have it and this is the plan. But just like you would change if something on the medical side changes, and you adjust your care plan on the medical side, it's the same on the educational side. There is a lot of trial and error. And there's always that ability to reconvene and talk about new issues or concerns and work through that system. And that, I think you bring up such a eloquent point that these systems are complicated to navigate.
Very complicated.
Both sides. and so making sure that you have, a team that can help you kind of figure out where to get the best resources to get what you need. We are a worldwide community, so of course it's going to vary where people live as well, and what country. I mean, we talk about, you're very sensitive about resource allocation and resources of where people live, and gaps that might exist. And I think that's another reason why it's so great to have large communities that can help connect people as well. So that is such a wonderful point to bring up with that in particular with school. Yeah,
I feel a lot of parents bring a lot of those concerns to us in the medical office, and we really want to help them, but we just can't do it. I get people saying, they think they have dyslexia. I'm like, I see that you can't read, but I just don't have that special training to tell you is this a reading disorder. And I wish it, sometimes it's easier to go to a neurologist than go to a neuropsychologist, which is not fair, right? Or sometimes the insurance will cover it to come to neurology, but they won't cover neuropsychology. And it's kind of like, it's not the same. We can just sit there with you and kind of say, yeah, we see what you're seeing, but I don't know. And even the neuropsychologists, they'll give recommendations, they'll make a diagnosis of an educational problem, but they still cannot go to the school and make it happen, right? So that's why you still need an IEP team at school, boots on the ground, doing that, because this is really more in the education realm of things. But it is a continuum, right? These medical problems have repercussions that affect school and learning. So, it's good that we're all working as a team the best way we can. And I think we still have a lot of work to do in that arena as well.
And I also want to bring up, because when we talk about early intervention therapies, when you have a learning disability, there are interventions and therapies and accommodations as well. So it's not like this is the saddest thing ever as well, because again, it's like trying to get the best support to maximize potential, which is always the goal. So it's not a hopeless situation should you get diagnosed with a learning disability either. Yeah.
You can always improve. I mean, that's the human condition, is we can always do better than the day before, unless you have a progressive disorder that where you get worse over time. And unfortunately, there are patients like that, but in the majority of the time, there's always the hope that tomorrow you're going to be better than yesterday, but you need the right tools to get there. Summer breaks are a good time to focus on what you need to work on. Just like if you were trying to get really good at sports, you would, hone on it and practice. This is the same, right? Your brain is trying to learn how to read or how to write or how to comprehend. So how do we practice is important.
For sure. Looking at our list, we'll bop back, I guess, to seizures for a moment, and then can wrap up. I think we've covered all of the questions that have come through the chat so far as we've gone, which has worked out well. But definitely one of the questions that came up, I know, is can babies have a seizure and not be exhausted afterwards with like what they call a postictal state, right?
There's so many different seizure types, and some seizures you can have a quick return to baseline. So I know that there's some key questions we ask to try to figure out if something's a seizure, right? So was the baby awake, eyes open, closed, blah 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 blah, peed on with their potty training, did they have a loss of bowel or bladder? Did they blink? Did they not blink? Were their eyes rolled back? Were their eyes to the side? And one of the things we always ask is, were they tired after the episode? Because these things kind of help us as like a list of probabilities. But there are some short seizures where you might have quick return to baseline, like bowel spasms, right? You're just like, you get cranky. And epileptic spasms, or some like there's seizures that are called myoclonic seizures, are just like really short. So yeah, and again, it's coming back to that earlier conversation that if you're seeing something, your mom and dad gut sense, or grandma or whoever is on the call tells you this doesn't seem right, or this keeps happening, I don't know what it is, just it's always okay to ask. We never get it's part of things we expect to talk at appointments. Any movements, what are you seeing? And you can always call before if you're very concerned, of course.
Yeah, very, very helpful. I'm going to ask this one question because I think and I'm going to frame it in a way that I'm excited. I just want to hear your response as well. But there's a question about trauma-informed care and how you might apply that to your practice. You get lauded in our community as being a very compassionate, welcoming, warm, helpful provider. So, I think if you could talk a little bit about your approach as, the human side, the non-technical side of neurology, and what you really try to bring to your practice.
I mean, this is a tough question because I think that's just my personality, and it's not an excuse or an explanation, but I know this is a job, but I do see it as these are people in crisis, and you have to be, even you have difficult information, there's no excuse not to share it in a kind, compassionate way. And it's tough. We have a very tough job. Giving bad news is not easy. I've done it so many times. I mean, I've only been practicing independently for 4 years, but even as a resident, there's so many bad news, and I know I still have more bad news to say, to give. It doesn't get easier the more you do it. And I think the day that it gets easier, you have to really reflect and say, wait, whoa, how did you get here? I think we kind of move fast in the day, and we can lose sight of maybe sometimes how life-changing these conversations are for the people sitting across from you. So I think trying to be mindful and in the moment, and just knowing these are people just like you are a person, And how would you like to hear the information, and how would you want people to treat you? And I'm not perfect. I'm sure I've had situations where I didn't read the room well, or maybe because of my own busy day, maybe I said an information one time and then I repeated it, and when I repeated it, maybe I didn't say it in the kindest way, because I like, oh, they already know, so I'm just going to say it again, right? I think we're all human beings. We're not perfect. Doctors are not perfect. We cannot fix everything, and we're very flawed people, just like human beings are. But I think I try to just be authentic. I also really like following babies over time, so I try my best to give all the information up front and be compassionate about it, because when things come up later, I want to say we've already talked about it, and I want people to trust me. So I try to be open. I think that's probably what my approach. I don't know. I can't think of any other way to do it.
I know, this is why, why we're so grateful to have you on our medical advisory board, to have your expertise and your passion and care that you show for, your patients, advocating for them, for their families. And just appreciate all that you bring, to your practice, and all the support you give to our community and everyone you work with. So thankful for you.
Thank you. That's so kind. I mean, I think we all want to do a good job. We're not perfect at it, but it makes me feel happy that people appreciate, and still want to see me after I've told them bad things.
Well, we say this, and we say it often during Awareness Month, that the NICU or the PICU is just the beginning for a long journey, and it's important to have people that you feel comfortable working with moving forward. So I guess the final question is, especially for and this is outside of the parent realm, I guess, but I'd love to hear, what would be your biggest advice for someone that's considering pediatric neurology, and how what you would think is so important for them to know working with families?
Yeah, I mean, I think pediatric neurology, pediatrics in general, it's different than adult medicine. You have to understand that you have not one patient, but multiple patients, right? Because the parents are also part of the people you take care of, and it's not one, it's multiple people. And that you have to be patient, and you have to be humble, that the parents are going to know more about the kids than you will, and that they will have sometimes better insight than you will. So you have to be humble. You have to be ready for taking care of multiple people in an encounter. And I think, the things that we deal with are, the brain is really the organ that makes us who we are as people. So it's intimidating, but if intimidation and gray areas excite you,
then you're in the right place.
Then we're in the right place. If that terrifies you and you want everything to be more precise, cardiology, GI, or pulmonary, you have to be comfortable in the gray space. But it's also a very exciting field. I mean, there's so many things that have happened. I mean, look at something like SMA. When I started my training, used to be a death sentence. I remember I gave bad news like that one time, and not even a year and a half later, look where we are. So it's also, very exciting field to be a part of. The patients are the best patients in the whole hospital. That's just my bias. I think they're the cutest, they're the strongest, the healthiest, the feistiest children in all of the hospital, and the parents are the best. So it's a good field.
Well, thank you so much again for your time today and for your support. Thank you everyone who has joined us today and for your incredible questions. We'll keep the dialogue going. We're always happy to provide more, answers, and we can, keep the dialogue back and forth as well. So keep asking. We have a lot of different resources that we've developed as well on our website. In particular, there's a lot of epilepsy content about HIE and epilepsy. So make sure that you check that out as well. And thank you again, and happy HIE Awareness Month, everyone.
Bye. I'm really enjoying all the stories, so keep them coming.
Thank you for joining us for another episode of Hope for HIE's official podcast, Just Say HIE. If you have a story you'd like to share, be sure to keep in touch. Learn more about the work we do and sign up for our newsletter on our website at hopeforhie.org/justsayhie. We look forward to connecting with you soon, and thanks for listening.